community rent monitoring and performance and the experience she has in all these discussions around what are the contributions and the role of community in the discussions around the remuneration agenda. So karibu sana Maureen Murenga. Want to use this or this?
Thank you very much, Ndwiga, and thank you everyone who has made time to come and join us. You know, a lot of science has scienced since the session started, and English has Englished until some of us are lost. You know, when we are lost in the science and in the English, we always ask, are we still saving lives? You know, is this still part of saving lives? But we know that we really need the science to save lives. So I'll break the science a bit and bring us back to reality. Like they've told you, I'm Maureen Murenga. I'm a two-time PMTCT beneficiary. The first time it flopped, like ilienda south. It didn't happen. But the second time it worked out. The first time, you know why it flopped? There was no treatment. It is that one of mimi na Yesu. So every day you wake up in the morning, you check if you've lost weight. You check if you have spots in your body. And you know, I was not very healthy with the pregnancy, and you're in stage 3 of HIV. It's usually not a good place to be. Sometimes you're saying the stomach is too sharp for a normal person. I think now is when I'm going. And one of the doctors in a private hospital, I knew my status in a public hospital, told to me in a public hospital. I got someone who offered to take me to a private hospital. And the doctor looked at me and said, you'll be very lucky if you have this baby. You know, this baby, you may not have the baby. But now what kept me to the extent of having my baby were the support groups. I went to a support groups and they told me, we have seen people who are in a bad shape than you and they've had their babies. You just need to take care of yourself, and these are what you need to do, and ensure every time you feel a little unwell, you seek services so that you have this baby. And so my hope came from the support group. I feared the hospital because they were the bearers of bad news, but the support group was the bearer of hope. So most of us went to the support group to ask questions. You know, the doctor would tell you this, and then you got back to the support group and asked, so we used that, and that is why I stayed long enough to have my baby. And in as much as I was unable to prevent HIV because there was no treatment, he's a healthy adult of 20 years now. So one of the things that happened during that time, when he was about 3 years, we started getting treatment. And it started with people very 200 and below, inaitwa CD4 count, so that you're enrolled on treatment. So there's a time I heard that MSF Madare was enrolling people. And I went there at 5 o'clock, and the queue was so long already. They were enrolling 100 people, but the queue had 150. So the watchman is telling you, tayari tuko number 150, you'll not even be enrolled. So I went home. But one thing the network people knew was where to find help. We knew where to find food because nobody was employing us. If you had HIV, you would not be employed. They would test you and deny you the job. So ours was to take care of each other, because hospitals are also discharging people who are in stage 4. You are told to go home and get palliative care. The people at home are also scared of you. So it is the support group people that were helping each other so that when your turn comes, you die with some dignity. You find someone who can bring aspirin. So my child had a low CD4 count. Yet, I mean, there's no pediatric formulation. So you're told that was our total bado. But Stavudin was there for adults. And what we did is that because I had, my CD4 could not allow me to get, someone got for me who had a low CD4 count, enrolled in 2 places, and got for me something to give my child. So I was breaking adult formulation for him. I'm saying, instead of watching him die, let me try. You know, women try. And so I tried that. It wasn't scientifically proven. It wasn't something we were disclosing at the facility, but it was something that we were trying to ensure that our children don't die without a trial. And like I told you, he's now 20. So we have had ways of, as community, of working and finding solutions to some of our challenges, and therefore that is the power of community. So when we go to the facility and we are pregnant, the first thing they do is testing. You know, testing is a must. So when I was having my second baby, I had treatment. I was virally suppressed. But when I went to I presented myself to the antenatal clinic, they told me I have to take a HIV test. And I told them, I know my status. Before I tell them even the status I know, hawa mama wanajifanya wameenda shule ni wajuaji sana. Hiyo status yako ni yako. Here you must be tested. And I'm like, but I haven't. No. Unapimwa ama uende. So already that was a scare, you know. So I said, okay, fine, they can waste their test kits. I'll sit and get tested. So I sat there, and I was there with about 8 young girls. So they came and did group counseling. Wanatuliza, mnajua kwa nini mko hapa? Mtu anaraise mkono, tumekuja kupimwa. Mmekuja kupimwa nini? And then someone says, ile kubwa. Then mnaelewa ile kubwa? Then all of us nod, tunaelewa ile kubwa. And then they say, ikitokea line mbili inamaanisha nini? Uko nayo. Ikitokea line moja, hauna. Na si unajua ikitokea line mbili kile utafanya? One said, And then they said, line mbili unameza dawa. Ikitokea line moja, uko sawa. And so bring your books. So now they finished counseling. So they took our mother baby books to the uko ndani. And then the first person was called inside. This lady came out with very red eyes. I think she had tested positive. You could tell her body language. She was very unsettled. She had cried. And 3 ladies said, hey, me, I'm not waiting for this. So they left. They left their mother baby boots and went away. They just said, they were talking to each other. And they're saying, hey, it is this bad. Look at how she's healthy. And we are thin. We are most likely not going to toboa hapa. So I'm encouraging them now that your books have been taken. Ingia tu, they say, sisi lazima. And they left. So when the nurse came, we told them, she was calling names and I'm telling them, they've left. And that is how we lose some people, you know, like, because the preparation wasn't done very adequately. And then when mine came out positive, the first question I was asked, how many sexual partners do you have? And sometimes this question is very innocent for the purposes of data, but it could be very intimidating for you who has not accepted your status. So you're saying, hey, I'm positive, and they're already thinking I'm promiscuous. So the person who is receiving the question is already feeling very judged. First of all, they're positive. This hasn't sunk well. And then you're thinking they're promiscuous. It is even adding the burden. And then you're sending them to another room. So she was feeling a bit safe. Wewe peke yako ndio unajua tuko wawili. But the mental mother is in another room. So you're sending them and telling them now that you're positive. You need to go and see the mental mother. So this information to the person is spreading so fast. And when they get there, they're given ARVs and they're given the baby prophylaxis. So it is too much. I've been tested. I'm positive. They think I have many partners. They have given me my ARVs. They've given me the babies. So everything you said after you are positive, how many partners? Nothing. That person had, most likely they didn't hear anything if it is their first time. Kila kitu ilienda. And so they're carrying these things. They don't know what to do. By the time you told them they're positive, they're already thinking back at home. How am I going to relay this information? Supposing he's not positive, kutakalika. Atanifanya aje? You know, so they're thinking of many things. And then the issue around disclosure. You already want to know the partner now and disclose to their partner. They have not internalized. So at this moment, we have left this woman. We are now focused on the partner. We are not even concerned about her health. We've already given her too much information. Now we are running. We want you to bring your husband. In the next visit, make sure you bring your husband. And in the next visit, true to your word, wale wamekuja na wazee, kujeni hapa mbele. Kama unajua umekuja na mzee wako, kuja hapa mbele. This poor adolescent who has been made pregnant by the uncle, ako huko nyuma. So she comes to the clinic at 8, she leaves at 6. When she goes back home, she's told ulienda kutembea. Mama nani si pia alienda clinic. Yeye alisharudi after 1 hour. What were you doing until 6 p.m.? So with that she's told you will never go back there. Uendangi hata clinic ni kutembea unaenda. And I tell you about the 3 girls who left without mother baby books. They already know what was written in their books. So they'll go to the next hospital. They will go through the other processes. So by the time for HIV testing, they know it is on page 4. They'll go and write non-reactive. And then now you'll be handling an unreactive person, yet they are HIV positive. And then, and some of them, they'll go through the process. You give them the mother baby book, it's positive. There's no way they are going home with that book. So they go to the next facility, like a new client, they're given the same book. So now they have 2. So when it's time for testing, they'll write everything. After you have stamped, they'll write everything, and then they'll write non-reactive, they don't have HIV. And then they leave, they throw away the book with the positive result, they go home with the negative, because the husband or the boyfriend is waiting. They use us as VCTs. They're waiting for the results to know if they're positive or not. So those are some of the challenges we experience. And so what we have done as communities to mitigate some of these challenges is that we have peer support networks. When we identify women in the community, we have them tested. We want to bring them to the facility treatment ready. So even when you are asking them about how many sexual partners, we have prepared them for all these questions. So now they are ready, they have dealt with it mentally, they are able to give you answers, and they are ready to start treatment and stay on treatment. So we share personal stories to reduce stigma, to provide psychosocial support, and to increase knowledge on PMTCT. And when they come treatment ready, believe you me, it succeeds. That woman will not have a child with HIV. And then the second one is treatment literacy. We teach them about treatment. Wanasemanga nilipo ile ya blue iko kwa chupa ya white. Nikarudi wakanipatia ile me-expire. And why? Because the color had changed to some, there's another one that becomes brownish. So they come and say, Miss Jameza dawa 3 days, walinipa ile me-expire. So we have to tell them that the color of the drug will change. All you have to master is the name of the drug and check on the expiry date. So we train them on treatment literacy, adherence counseling, prophylaxis, breastfeeding, nutrition, and everything they require. And then we also do community mobilization and sensitization. We do pregnancy tracking, getting people from the community. We do adherence support. We link to care and ensure that the ones we have linked are retained on care. So some of the lessons we have learned are that not one size fits all. Every woman comes with their level of need. There are people who are stable, who need very little attention, but there are people who need intensified care. Then we have that we need to follow up the children until they're 5 years. So we drop them at 18 months, but kuna wamama, they continue breastfeeding or culture or anything, something just happens and the children seroconvert. So let's follow the children until they are 5 years. And then we address barriers. Service integration is very important. Sitaki nikuje Monday kliniki yangu, Tuesday ya mtoto, Wednesday ya TB, Thursday ya family planning. So it's like I'm working in the hospital. So if we integrate the services, it becomes easier for us. And then finally, I'll let you know that the women who go through PMTCT successfully are the ones that can, the ones that are able to, the ones that are empowered. So we need to raise our emphasis on making sure every woman is empowered with knowledge and all the support they require. Thank you very much.
Thank you. Thank you, Maureen. Maureen is equally another professor. So you can, and she has a good experience in terms of PMTCT, and it's always good. So now I'll give opportunity to Reverend Kaida. I know Kaida, yours is short because we are dealing with how do we bring men on board in terms of EMTCT agenda. So kindly please come and give us issues around a summary of male involvement in this discussion. Thank you.
Thank you, moderator. Prof. Thank you, Maureen, and also my sister who is to come after me, and everybody on board. Allow me, I'll give a snapshot. I know I had a few slides which could broaden my short presentation, but I'll love to go straight to the very topic, men, the missing link. And when we talk of men as a missing link, since I was given this portion to tackle, I've been on a journey asking a critical question. Is it by design or by default that men are missing? And one thing before I engage us, I would love to say from my journey of experience from the late 90s, when I trained to be a community HIV and AIDS educator, to date, and having had also some milestones of experience with even the line Maureen has gone through, I realize, I will say, men are not missing 100%. And I will raise a few reflections on why men tend to lag behind a little bit on the journey. Then I will make 2-3 proposals which are very practical and what we have been doing. I do this when I know I've been working with men in the religious setting through NCCK, through also where I serve as a director, and also in Africa. I engage with men quite a lot from different countries. Number one, we have to appreciate that men and women are created by God. And this is a great, rich opportunity from God that we have both male and female. An opportunity of being procreators. And when I begin with that very statement, I want to say both male and female are where God started humanity and moves on to give the blessings to carry on with the gift of raising other children. Why do we find man avoiding matters risking in healthcare? I'll raise 4 observations which have been done and studied critically. And partly I'll borrow from one of my close friends who served in Nigeria at the geriatrics on medicine for older people. And having come from the World Health Organization, he was very critical to study the trajectory of men in healthcare, and realized, although we find men due to the testosterone hormone, men are seen to be more stronger, and it is taken that way. But proof is, as I stand, men stand out to be the weaker sex and the sicker sex. Scientifically, it is proven, though from masculinity side, from biceps, from the brute strength, we may think they are the stronger part of the design of God. But I will say, maybe even what Maureen has given here, men, number one, fear vulnerability. Men, we don't love being vulnerable. Even when we talk of testing and treating, if men are not handled, understanding a bit of that psychology, the man will leave and will never come back. I've journeyed with men now the last 26 years in ministry, and I've realized the following three observations. One, men fear bad news in the sense men often worry that the symptom they may have been experienced might lead to what we are calling the doomsday. And so they avoid thinking about and even consulting the healthcare provider. So that withdrawal, and we are calling men, see, we say they are a missing link. That is an area whereby men, in line with the vulnerability, with the stigma, it challenges them to not to really, they have that internal fear. Secondly, men are embarrassed, or the embarrassment of masculinity complex, where it can be hard to men to acknowledge, even to a healthcare provider, that they have a problem, particularly which is involving their ability, even in matters, their sexuality. Thirdly, men have that element of stoicism, not all, whereby men will not admit they have a medical issue which may be diagnosed, maybe incorrectly, and so some men would run away. And finally, men have what we call the overconfidence. And here a scientific research in Orlando Health Clinic survey found a third of men thought there was no need for even the annual health screening, or even it revealed that 2/3 of men thought they were naturally healthier than other men. So generally men in their journey of health, we have that tendency. Even we do treat ourselves so much, so we medicate ourselves. I'm speaking we, so I'm not running away from the reality. And number 5, healthcare is taken by most men as an priority. Like currently, if we check, when we say your health, your wealth, a key slogan, you may find when we say your health, your wealth, most men is vice versa. You can insure your vehicle while you don't have a comprehensive cover. What does that mean? Men value material things more than even their health. And so on the line of care, where now is the challenge we are addressing. Coming even to the final part, the societal norms and societal cultural factors. We note men have also been down due to gender, the negative retrogressive cultural values, which need transformation as we move ahead. And so, having found this, is we would think of men contributing positively to the agenda at stake. Although we have said Kenya has made good progress, the 3 recommendations are what I would give on a men coming on board. Number 1, as men, we must accept that we are equal partners with our spouses, where we need to begin taking care before, within conception, and even after conception. I'll be calling it my 3-prong approach, which will also give a solution which is already attempted in the adolescent stage. What do I mean here? Care begins by expressing the concern of yourself, your partner, by going through testing. And if men accept testing at the very early stage, they would also help. And if they accept following all the way, being consistent, they would help by accepting even to own up that children are a gift from God and a heritage. So we are not after only siring children. We should give that companionship through nurture, through taking care around the family. But you remember, it is theological that the blame game, right from the creation account in Genesis 3, Eve, I would quote from the Bible, man has a challenge of blame game, whereby he would just point the finger. And I would say, man tends to hide if something would be stigmatizing, and men hate shame. And so my proposal here, for men to accept testing and treatment, we have also to contextualize and even customize some of our facilities, and even on the language we use on men. Men we will repel. I've been handling men directly in church, and I realize if you mishandle a man, he can disappear for life. But if you befriend and you encourage, you give hope, they tend to remain. And so, where we are today, as I also speak strongly, even on women, they have that ability. With the area of the scientific proven level of testosterone, that at the first 8 weeks of pregnancy, the testosterone hormone is released in great quantities to the life of a man or of a baby boy. And that one causes the divergence between the male and the female. Lastly, the third way forward, as the moderator is coming, as men, I would recommend for mother to child response, where it is scientifically proven.
To really give us a brief in terms of leaving no one behind, and especially engaging adolescents and young mothers in a rumination agenda. So, my sister, you can come over. I know we have only 15 minutes, so she'll take like 5 minutes, and then we can have 10 minutes of Q&A.
Hi, my name is Zipora Acheng, a 22 years old advocate and a HIV champion in Nairobi, Kibra. First of all, I'll start by saying that I played my part, but I got my child at 17 years, of which I was in Form 2, without the knowledge of how to take your ARTs, and I was afraid of the stigmatization from both school and home. Living with a single mom, I thought that life was endless because I was the one to change my family, but I messed up by getting pregnant at early age. And as we know, our society, when you get pregnant, you have lost everything. And from there, stigmatization rise because you may not have friends. They'll be stigmatizing you because they don't want to be like you. So I didn't give up. I followed what the doctor was telling me. And now I have a 3-year-old daughter who's always calling me big sister, and she's negative, and I'm happy because it is an achievement. I'll start by saying that we have to insist on HIV prevention in pregnant and breastfeeding girls and their partners. I am positive. I have a partner. I don't want to lose him because if he knows that I'm HIV positive, he will leave me. So what do? I'll not tell him. And if I'll not tell him, definitely he will come to know. Because as earlier we have been told that you have when you go to, if you want to start an ANC, you have to be tested. So me, I always tell myself that I'll rather tell the truth than like nifiche. Afadhali niseme akaya kijua, akwe psychological prepared than akuje ajue baadaye ndo aniache ikiwa mbaya. Then our partners have to include us, that we have to go to the clinic ikianza tuende pamoja ndo aambiwe prevention, because in our society rumors ndo inasikika kuliko ukweli. So unapata a young youth, a young mother ameficha hizo dawa zake, anazimeza leo, ana make sure like home pia maybe hayuko poa, the virus is not good. And again, what I know and in my experiencing of living with HIV for 22 years of my age, drugs cannot work. The ARVs drugs cannot work if your brain is not settled. Definitely you are doing nothing, because the medicine, unaweza kuwa tu unameza dawa lakini ukienda kupima viral load unaambiwa zipi viral load yako bado iko juu, but you are always there taking medicine. So mimi naona like wakifundishwa, hata hao mapartners waengejiwe, uende na umeshika partner wako mkono, mnaenda mnaangaliwa, mnaambiwa it will be good. Then hiyo disclosure pia unaitoa mapema, unamwambia like mimi niko positive but kuna vile unaweza jiprevent. Mimi nikichukua dawa nita acquire the rule of U equals to U, which is undetectable and transmittable. Nikimeza dawa siwezi ambukiza mtu, but wewe pia unafaa ujikinge kwa sababu atujui ya kesho. So unapata anapewa prep pia juu tuwezi jua njia zake pia. Alafu hiyo knowledge amongst women and young girls, tunawaelezea ukweli. Siku kuja tu kwa clinic unabrashua vitu na unaenda. You have to be told ini kijiko that this thing is the real one. Then viral suppression and retention in treatment for adolescents, girls living with early HIV. Una make sure that unamwambia uko na mtoto, sai wewe si mtoto, wewe ndio unaenda kwa mama ya mtoto, ambapo huyo mtoto unafaa wewe ndio ukue kama direction yake. Usipomeza dawa poa utamwambukiza, na ukimwambukiza atakuuliza maswali, na kikuuliza maswali itakuletea stress juu sijui wewe pia utamuelezea alitoa wapi. You know, sometimes we as human beings tukibembelezwa pia tunakuaga na kiburi. Juu nitakuja kwa hospitali daktari atanibembeleza, jioni ndakuja ndasema after all atanibembeleza, but nikiambiwa kweli na niambiwe think about the future, it will be better. Then address stigma and shame associated with early pregnancies and SGBV. Unakuwa friendly na huyo msichana, unamuuliza unapitia nini kwenu nyumbani, atakuwa free na wewe kukuambia. Si ati akikwambia utaenda uite Dr. Moreno uambie Dore unajua zipi alifanyika hivi na hivi, no, definitely atasikia. So unafaa kama ni hapo mnamalizana, unamfollow up like you be as a best friend and a family. So kutoka hapo hata yeye mwenyewe life nenda tu smoothly na kuambia mimi hata mtu akijua ni shauri yake, because she has knowledge and there she can stand for herself. Hata mtu amwambie nini. Like me, I always talk about myself. Mimi mtu akinituka about my status, mimi mwambia better wewe unajua yangu. Think about your life. Mimi mine it's going on, inaendelea, and there are siwezi kata na meza. But wewe jichunge juu unaweza katwa na mabati, wembe, anything, you never know. So we have to stand for, we train other youth to stand for themselves pia, because ukisema unajificha you can't run. HIV is in you, not outside you, na ni kitu huwezi toa weke kando, iko ndani yako. So you have to take it as a part of life. Supportive and exclusive breastfeeding for teen mothers, stigma and discrimination. Unamwambia mtoto anafaa anyonye for this period, PCR inafaa ifanyike time, yani you take her through the sessions mpaka aelewe. Then unamwambia maintaining HIV exposed children and teen mothers to prophylaxis. Unamwambia akipewa hii nevirapine ama Herceptin for this period of time atakuwa. According to me, at first niliogopa juu niliona mimi na meza dawa, mtoto wangu pia ana meza dawa, but that was rumors. Vile nilipata mimba, daktari aliniambia zipi ukipea mtoto wako dawa vizuri na wewe umeze dawa vizuri, possibility ya kuambukiza mtoto ni kidogo. And which I did that. Nata ilikuwa nilimaliza shule last year December. Nikatoka January 5 ndo mtoto wangu niliambiwa like she's negative. I cried because sikuamini. I was happy because at last hiyo burden ya kusema like mimi niko positive, mtoto wangu ako positive, nitamwambia nini iliisha. Sasa sasa yake she's 3 years, but kwetu me and my mom, we are the one taking medicine, and I have 4 siblings. Wako na lugha. Hata mgeni akikuja, saa 4 ikifika unasikia tunaambia nanga, saa ya njugu imefika, chukueni maji. So someone can't know ni nini inaendelea. And my daughter mpaka saa 4 ikifika na niulizanga zipi hujachukua njugu? Like it's a motivation, because ananiuliza hujachukua, and of which akigrow nitamwambia like I was born this and this and sitaki pia wewe ufanye hivi na hivi. Like we have that conversation na watoto wetu juu ukimficha shule pia ataambiwa. Shule ataambiwa ukicheza na vijana utapata ukimwi, of which kucheza ni mchezo tu. So we be frank with our children na tunawaambia ukweli and all will be well. Thank you.
Those are experiences that we can learn from, and I know it is very important to really also engage kina Sibora na wale wengine in the program. I know for us, Professor, when we are technical people, sometimes we don't value people who are not within our vertical program, and it is very important because such information can really be able to give you some direction and strategic thinking around how can you be able to do things differently. And how can you be able to handle some of the issues that are not within the mainstream of the medical care? So it's very important for us to consider so that we can be able to ensure that we implement very well. I know there was somebody who was online, I'm told by Christine. I think, Christine, you need to guide us whether we need to involve our colleague who is online, maybe for 5 minutes. Is it okay, Christine? Yeah, please.
A little bit of echo on my end. I'm not so sure I can still hear the echo. But it's an absolute pleasure to join you all. I'm sorry for the delay, basically just due to competing priorities from a travel standpoint. Be that as it may, it's been an interesting session to learn all the aspects from a HIV standpoint, all the way from across the value chain, is as what we'd call it in the private sector. Having said that, I was asked by Professor Christine, Dr. Christine Jogu, sorry, and Angela Langat. I'm not so sure about the title to use. Sorry about that. And the question was how are we going to address or end or eliminate a pediatric HIV? And from a private sector standpoint, what is your opinion? We always look at this kind of questions, and at this point, I work with Gilead Sciences. Gilead Sciences is based in Foster City in the US. I'm currently in Cape Town, South Africa. I used to live in Kenya at some point in my life and my career. Then I moved to a few places. Now, for a few years now, I've been living in Cape Town, South Africa. And with Gilead Sciences, we work towards the science and the commercialization of medicines, specifically looking at the disease areas of HIV, hepatitis from an Africa standpoint. We're looking at B, C, and D elimination or treatment for hepatitis B and D. Then outside of Africa, we go above and beyond as well. We're trying to also do the same in Africa from the space of oncology. You might see some of our work specifically in triple-negative breast cancer and multiple myeloma and a few other cancer areas, oncology areas as well. Now, to address the question, I have the opportunity to sit across different conversations with people from different sectors and different parts of the world to ask the same question: how are we going to eliminate pediatric HIV in Africa? As this has been mentioned before, Africa is the most severely affected from a pediatric standpoint, adolescent standpoint, adult standpoint. New statistics were released, I think, at UNAIDS, and it showed that Kenya is still among the top 20 countries with high incidence and high prevalence of HIV as well. I know that there's been progress towards, reducing that, and I appreciate that because I know everybody in this room and outside this room as well have been involved as part of the process. Now, I'll just speak about it from 4 or 5 different angles. And the first that I think is important and the center of it all is from the patient or the person. So at the IIS in Brisbane, Australia, a few weeks ago, we were looking at it in terms of person-centric initiatives. How are we going to make all our programs, or most of our programs, all the science and everything that we do, to be more person oriented, so that we are not actually just looking at what would work for us, but what would work for the patient. So it needs to be individually tailored. So it's not just industry players who think about this is what can work and prescribe it. It needs to be a collaborative process. So person-centered care also looks at the behavioral aspects of disease prevention, disease spread, and obviously the treatment side of it as well. So from the prevention side, I know this has been stated over and over again, but part of what we do in the pharmaceutical side is actually looking at medicines that we can, work towards clinical trials that can be used, that will be more resonant to what is the behavior of the specific population. We have some clinical trials that have been done in Kenya, in Uganda, in South Africa for some of the medicines used in prevention, and we've seen that scientific involvement or data, changing towards more person-centric approaches towards healthcare. Then from a policy and payer engagement standpoint, so policy would be, people within the Ministry of Health, key opinion leaders who influence program management, design, implementation, guideline reviews, and interpretation of those guidelines. What is it that we do that is more friendly towards the pediatric population? I keep telling people this, when you look at pediatrics, most people focus on ending or eliminating pediatrics, and they look at the pediatric population today. So they're looking at people between the age of, from, newborns, infants, all the way till, 16, 18, depending on where you're defining it from. But I think, we need to look at it, from a multi-pronged approach. So there's that age cohort who are currently in the pediatric spectrum. But if you're looking at it from an MCT standpoint, which I know was presented really well at the beginning of this session, we have to look at future parents. The future parents today actually do not have all the awareness opportunities that we had in the 90s or in the early 2000s. Most of them have actually stated that they feel that they're not empowered enough to know about HIV. And we've seen in conversations across different social media platforms, different forums, that they say that sometimes it's much easier for them to accept HIV than pregnancy. And that shouldn't be the case. So I'm not saying that pregnancy or HIV is easier, but it should not be the case that people do not know enough about HIV to feel that it's comparable or incomparable to pregnancy. So from a policy level, we need to actually engage and find strategies that actually cater to or be resonant to who the youth are, and not just today, but tomorrow as well. So from an MCT standpoint, the parents of tomorrow are 18, 20, 25, 30, they need to be educated as well. Then from a provider standpoint, this is where healthcare workers come in. I work very closely with healthcare workers, having been being a healthcare worker myself. And I like what the Ministry of Health or NSDCC are doing towards, the education program that will help activate that channel, because there has to be a high index of suspicion first. I remember during my pediatric rotation when I was in the university, Professor Ruth Mdwati was one of those people who actually told us over and over again, the high index of suspicion is actually what guides towards what the clinician will think about in terms of either, further assessment, diagnosis, or whatever it should look like, from screening to linkage to care. That high index of suspicion, the eyes see only what the mind knows. So it has to come in the mind first. And from a pharmaceutical company standpoint, which is the last part of what I'll speak about, because I know we are out of time, I look at it from the innovative side. So we're not just looking at creating products that resonate with people or are easier for people to take, because we should not be product-centric, we should be people-centric. So part of that is actually innovating solutions and working with technology companies and innovators to look at what we can do with artificial intelligence towards disease mapping, epidemiological trends and assessment of that, supply chain optimization, and actually just supporting government and health stakeholders within the healthcare industry to be more prepared for whatever it is that is either happening or is coming. And part of that also involves multi-sectoral collaboration and dialogue. So working with people who or industries where patients or people will more likely be able to digest information or find it easier to access information, that goes across the spectrum. sporting companies, sporting, I mean like sports. So in looking at football, basketball, swimming, because that's also healthy. So think about it in terms of how it also has a holistic approach to healthcare, but also communication companies, entertainment companies. So just walking through multi-sectoral dialogue and making it interesting, resonant, and making it very, very appropriate for the populations that we serve. So that's just what I would say. And I'm really grateful for this opportunity and for getting to know all I have learned about Kenya. Thank you, Angela and Dr. Christine Jogu and rest of the team. I appreciate it.
Thank you. I think we have come to the end of our key presentation from our panelists. Now we have like 7 minutes. So I'd like to give this opportunity to our members. Maybe if they have any question they can be able to ask. You can direct the question to the panelists that you feel will adequately be able to give an answer to your question. So maybe Christine, you assist me to pass the mic. Any? Yes.
Okay, my name is Charles Kalue Kibana. I work with Coptic Hospitals in Nairobi. My question is on nutrition. We have heard so much about the clinical and even the community welfare, but we also need to, for me, I think we also need to see how we deal with the nutrition for our mothers and our pediatric, because sometimes it's because of knowledge that maybe the mothers are not able to maybe feed their children well, or maybe feed themselves well, and then in that confusion of maybe lacking of proper nutrition knowledge, they also get at risk of also contacting the virus. The second one is on men in terms of the family planning. I think men should also be equipped with the use of family planning for their ladies, because it also delays getting pregnant, and this can also help in terms of the health of the mother. So that knowledge may also be important. I think that is a comment. Thank you.
Thank you so much, Professor. Thanks, Maureen and Rev and our young person for the wonderful presentations. I just want to weigh in on what Maureen has said briefly about the interventions of women living with HIV. I don't know why we keep, it's like we are imposing ourselves on the program, saying that women living with HIV can add value to the program, because even when Dr. Pato was presenting, there's nowhere a mention of women living with HIV, specific women living with HIV, because it is women living with HIV who can infect their children. So bringing in that component, as our young person has said, it's very specific. It's that woman living with HIV who needs to adhere to her medication. It's the woman living with HIV, whether young or old, who needs to give prophylaxis to the child. So the involvement and the interventions that can be brought in by women living with HIV into the program need to be seen. We should not be singing about it, and yet even when we are writing things like now, this paper, what Dr. has wrote here about the introduction, and this component is lacking. So that even when we say as women living with HIV, this is what we want to do. Yet, even when we are talking about the RRI, we don't appear anywhere. When people are talking about training, maybe we can, it's just on the periphery that maybe there will be a webinar somewhere, but not a specific interventions that is targeted towards women living with HIV. So I'm just emphasizing that it's vital that the contributions of women living with HIV are seen and are also part of this process. As the UN leader said, it's the community at the center. And when we're talking about the PMTCT, the particular person who is very, very vital is the woman living with HIV. The husband can talk, the relatives can talk, any other person can talk, but the person who will bring the impact is that woman herself. So thank you.
Okay, my name is Anwar Remo. Here under Kenya Red Cross. Mine is just an input, or even if I can say kusisitiza. We have already been told that, okay, from the presentation, it was told that we will make a change by being innovative, doing things differently. And then the professor told us that we should, as youth, we should be part of the research in everything that is being done in matters concerning the PMTCT or whatever that we have been talking about all through. So this means that there's nothing for the youth without youth. The youth must be involved in everything. It may be not possible for those youths maybe to give the output like the professor, but in anything that we give, tunapeananga tunasemanga kwa ground vitu ni different as youths. So we give the reality that is there in our community, that is there among the youths. We have already had the speech from ZP. Whatever ZP she has shared, it's whatever that is happening and it is real in her life. That didn't mean that tulikuwa tuna expect like ametoka university ndio amekuja kupresent. But whatever she has shared, it will really like help the youth outside there. So it's all the same that we need to involve all youths. Then there is that point Maureen said that the support group really helped her in everything yenye alifanya during the clinicals. Like we need to emphasize on giving those mothers or PMTCT mothers the support group they need. Those are the platforms that they will open up, they will share and give feedbacks from even the community or even from the other members in whatever they do. So mine would be just that. Thank you for listening to me.
Thank you, Prof. You've actually put me on the spot. My name is David Kimosop from USID, and I'm happy and glad to be part of these discussions. I want to really appreciate the team and the panelists that they've spoken. I think they've spoken to what is happening within the EMCT arena, and they've given us a lot of way forward and recommendations. Prof is my mentor. I started long time ago. I'm not young, by the way. And immediately after the university, when I was doing my internship, I took a keen interest in EMTCT, and this was having rotated within Kenyatta National Hospital. So during my internship, I remember interacting with Prof. Nduati, and upon my interaction with her, how she spoke to EMTCT, pediatrics, I was so keen on being part of these discussions. So I took a lot of keen interest, and I managed to be trained. And it is through that training and more understanding about EMDCT that I found myself in this arena. So I actually got my first job immediately after internship. And this was because of the passion that I developed earlier on. So I'm challenging the young people, and that's why Prof wants me to say that. I'm challenging the young people that it's very possible for you to develop interest when you are still young, and you can play a role, however little it is, even when you are still at that level. I started playing my role when I was doing my internship. And it is after my internship that I've been able to grow up to the level I'm in, starting when I was a young man until when I'm currently at a USID level. Thank you.
You know, they turned up, they had just finished their nursing training, and there were those challenges of getting the nurses with degree training were having challenges of getting hired. And we happened to be at that time doing the scaling up of PMTCT programs in the counties, in then districts. And we said, okay, you come and let's see what needs to be done. And so really, as a young person, I want to illustrate that a young person is not just a young person who for bad reason, bad environment is out of school without, and they are the focal people for the PMTCT. So a true grown-up having oversight and then having these teams of young people coming in to support the program. So the importance of those teamworks, the older and the younger. Now, I'd like to say that all along, even the research project there, the follow-up of mothers in the PMTCT program would not have happened the way it did if we didn't have fellow women supporting each other. So you're very correct in saying that I think there's something that has fallen out of the equation. I like to confess that I'm not madly enthusiastic about the strategy that is going on of community health workers as a primary point of healthcare. I'm not madly, there are issues I have with it. But if I had said that actually what we are looking for is mentor mothers, that one, I'll be the one carrying the flag at the front. And I can assure you that that one will work. And it will work and it will be very successful. So maybe those two positions we are calling community health workers, let's get the mentor mothers on board, and you'll see that this elimination of mother-child transmission will take place. Now, the other population we must keep an eye on is the lady who is using substances, whether it is alcohol, whether it is the heroin, whether it is the cannabis or whatever. Those ones are very vulnerable. Those babies need to be followed up. Yeah, those ones need great support. Yeah.
And again, I will say that my mom always tell me that if you want something, you have to go for it. We can't be, hatuwezi kuwa tunafuatilia madaktari ama caregivers. They are there to show us the way, but we have to keep the spirit going, because dawa si daktari anameza, ni wewe. And you can't, hauwezi kuwa ufanye kenye daktari anakuambia, then you're there complaining that your daughter is infected ama your son. You have to keep the spirit going. Data daktari enyewe kiona narudi chini anasema enyewe zipi tried. So again, we have to emphasize on ourselves to say like, mimi I'm a HIV positive. I want to prove people wrong who are always there saying that HIV is big, but you take your medicine. Even hata ukistand mahali mtu anasema you are not sick. Mtabishana hiyo kitu mpaka kesho. But we as youth sometimes we want to be followed. I'm sorry to say this, but sometimes we want to be followed. We create attention of which unataka ufuatwe mpaka kwa nyumba. Na ukifuatwa kwa nyumba, stigmatization will come there. Majirani wanaona watu wanaingia kwenu, wanatoka. Then our self-contained houses, jirani yako next door, anasikia. So some things ni sisi wenyewe tuzifanye. Like, kama nimetumia example ya my daughter, anajua my ARVs ni njugu. Unaona? She always see me, nikikosa kumeza ataniuliza, "Ma, zipi mbona leo hujameza?" Unaona? So we have to keep the spirit moving. Ndio hata kina prof wakienda huko UNAIDS waseme dawa, okay, children are being infected, isikuwe ni mother to child transmission, ikuwe ni kitu ingine. Tuseme maybe hata alienda Siombi, nasema for example, apatane na mabati maybe mkate, but si mother to child transmission, because sai HIV is advanced. Si kama 201 mpaka 204 yenye dawa ikukua vile kina Morino amesema. Now it is advanced. Na siya learn through support group na she is here, the son is alive. So sometimes ni sisi pia wenyewe, we have to emphasize and be strong for ourselves. Ndio Mungu na daktari na wengine waingililie katikati. Thank you.
Thank you very much. I think from Achieng, there are key things that we really need to consider. And I also want to align and support what the professor is saying. Professor, I want to tell you that the way that program is supported and the way it is designed by the framework that is there is more of a community, is more of a county-led program. It has no specific design. So even if I want to employ all of my CHPs as mentor mothers, I will be able to do that. It's how people, as my sister said, is how much are our people, and especially I had a discussion yesterday, sorry to say, with the end of Team B program. When I was doing this year's budget, I didn't see any initiative from our county Team B coordinators in terms of protecting the space for the allocation of money, equally to the CASCOs. It happened. So even now when we are trying to design the CHP program, I've not seen the program guys coming along to protect us. You have said how much we do include and consider mentor mothers as part of the people we are trying to support in that program. So it is not a program that I may say, and especially at the county level, and the way we have discussed with other CECs, that is cut and paste. So it's a program that the counties are deciding on their own. And for me, some of the areas with the experience in PMTCT, I can tell you a quarter of the people that we employ or will consider to engage are people who are living with HIV in that direction. So it's the way you design, it's the way you understand, and how we are able to advocate for the areas that you feel are the needs of the community. So it's something that, as you have said, I may also need to raise with my other waziris in health to see how some of those things we can raise and consider as part of the component of community-led programming. So I'll be able to do that. Thank you, Professor, for reminding me that. Yes. Yeah, sir, yeah, good. Yes, let me give my team here maybe 1 or 2 minutes
Parting shot.
parting shot,
Yes.
so that
Mine, I would make this recommendation, and we are finding it working. Number one is we are making the conversation in this panel. You realize what we call the ground perspective, the reality gets into the nerves. Currently, for men to break that element of fearing vulnerability, we are recommending safe space approach, whereby it has been proven through generations, men have got age groups, while women have their dynamic, they can make disclosures. A simple survey was done on how we use the public facilities for washrooms. We get in there as men, we don't even greet one another. We go out because you live as a suspect to the other. While women, when they use the facility, even they can greet, they will tell one another there is some water there, you sleep. But for men, we are serious. We are always on business. It's a high time when we should change that, we be a bit friendly. And what we are recommending, moderator, is this. Whenever men meet in their forums, we are introducing that component of comprehensive life through a health talk, whether it is healthy tips, whereby we know knowledge is power. And this one is helping. Currently, we are making the locals collaborate with the hospitals, with the many actors, whenever we have an opportunity. So that collaboration and a partnership would carry the effect. So thank you.
Thank you. We have one of our colleague, our participants. You had something to say? Yes, I remember.
Thank you so much. I want to bring in the aspect of stigma. And on the ground, we've been doing some work on PMTCT. So we realized when a woman is pregnant, she can take her medication very well and she can deliver safely. But when she goes and is breastfeeding, sometimes things go wrong there because more often than not, people come to see the baby, maybe the mother-in-law, and you realize that is the time now this woman may skip her ARVs or even for the baby. So stigma is a very key issue in all for us to be able to eliminate transmission of mother to child. So my thinking is that as we move forward, and alluding to what Maureen said, that she got a lot of support and comfort from the support groups, the people living with HIV themselves are able to encourage each other and give each other education. And through education, that's when you learn, you can even be able to overcome stigma. So for me, I really would support, and I'm concurring with the professor here, that the mentor mothers will be more productive than a professional doing this work. A mentor mother can counsel, can share experience like nilikuwa hapo na nika overcome. Hata watu wakijua uko na HIV, kwani watakufanya nini? Bora mtoto wako akue mzima. So really, I think I agree totally with that. Thank you.
Thank you very much. I think it's also something that maybe preferably, Dr. Neri, maybe you can be able to prepare a concept, which we can also be able to, for us, to have a discussion with the PS today in the evening, so that we can see whether we can expand the CHP program also to cover mentor mothers. Something that I know the president may also be willing to have those kind of ideas beyond what is currently being supported. So it's a discussion that some of us can take up there and have a discussion, advocate, and have that discussion to consider mentor mother program being expanded beyond the CHP. So it's something else that if NASCOP feels is something that some of us can be able to push for you people, we are ready to do that. Thank you. Okay. And oh yes, Maureen, my sister here. There is no PMTCT without Maureen. That's what I used to say. So if Maureen is not there, PMTCT is not there. Maureen, tell us.
Still believe that we can end pediatric AIDS. We have the science, we have the tools to end it, but we have to address the barriers. We have to be very deliberate in addressing the barriers. And another conclusion that, and some of these barriers are the ones we've talked about: stigma, we have talked about lack of adequate information, we have talked about other social barriers, such as someone mentioned knowledge on nutrition, but sometimes it's not even the knowledge, it's the food that is lacking. So we have to be very deliberate to understand which are these barriers, because we have the solution. So we just need to navigate the barriers and get to the solution. And then another thing is that we will not get there without the primary beneficiaries. Like, for example, we will not have vertical transmission without women living with HIV. So let this be our primary area of focus. Who are these women living with HIV? Where are they? Why aren't they able to eliminate vertical transmission? And I've seen so many recommendations done, but are they the issues? Are they really addressing the issues from these women? And I'm glad, Prof. Nduati, you talked about doing research, talking to the women. Why aren't you able? Why did you pass the infection to your child? Tell us what happened. And then you hear the different issues, and you know that the most common one is this one, and then we address that, and it's a game changer. And then the engagement of communities is not that we want a parallel kind of epidemic response. We want to be part of the partnership. So even in the RRI, when they are training, we want to be part of that training that is going on. If people are going out to find the missing children, we want to be part of the people going to find the missing children. Our peers sometimes feel more confident with us than they are with the healthcare providers. And so we want to be that link between our women and the healthcare providers. And UNAIDS said in their submission to the Global Alliance to End Pediatric AIDS, they said the interventions being done at the community level that are targeting women living with HIV should be 80% women living with HIV led. So I think if we take this advice from studies that have been done, results that have been shown, countries that have done well, we are going to win this fight by 2027 as we have committed as a country. Thank you.
Thank you very much. Now we give opportunity to Professor to sum up.
I think these folks have done good summary. I just want to raise one last issue.
Good.
Who supervises the community health worker? What's going on currently is not correct. The community health worker is being supervised by the public health officer. Public health officers are not trained to provide clinical services. That's not what they are trained to do. And so in having them supervise the community health worker, you sometimes start creating a space or a service that is actually abusive to the person you're supposed to be helping. The community health worker who's walking into somebody's home to talk about whether you are immunized or you went to the ANC should be supervised by the public health nurse. That is a person who has been trained to do so. And that's part of being evidence-based in our practice.
Good. Key considerations as we design the program, I think all of us need to participate in that space, as Professor is saying. And I know there was a letter that was written to the counties and it brought issues. I had to have a meeting with the PS Public Health yesterday to have a discussion around some of the thinking that we had when we were preparing when we were developing the PCN operational manual for this country. Some of the people who are giving advice at the ministry may not be having the idea that we had, as Professor said, especially at the sub-county level. I think we were very clear. Public health officers were to read, and the read of the primary health care at the county level was supposed to be the family physician and all those discussions. And more mainly in terms of coordination, I think it was not specific to any kanda. Like if you go to Nyeri, the focal person for community health is a clinical officer and other areas. So it depends with the county choice. In Embu, the end of primary health care is a family physician, and it's also the end of community health. So it's somebody who can be able to give ideas beyond that, and also issues around how to operationalize PCN. So it depends with the counties, but as Professor said, some of those things we can really also be able to discuss with our colleagues so that they can see the sense of how to ensure that as we establish these networks, as we talk about the framework for community health promoters, what are the key considerations you need to put in place? Thank you, Professor. I will carry that and share with my colleagues. Thank you. Okay. Oh, we can now end up. Huh? So thank you, Christine. Thank you, team. Thank you, panelists, for giving us this opportunity. I think it was a good session. I know for PMTCT, Christine was telling me it needs to take 2 hours, but I know because of the interest of people who deal with the maternal child and maternal neonatal and child health, I think is one of the topics that takes the longest time in terms of discussion. So to sum up, I think we are on the good highlights of key areas that we had considered to be discussed today, but more in addition. is the issue around expanding our program of CHM, community health promoters program, and also have a discussion around the Kenya Mentor Mother program being incorporated in the same. I think we can make that resolution here. Issues around considering beneficiaries, and especially now we are talking about vertical elimination. And we also, I think, is also in line with also considering some champions for this program. You know, for us to ensure that we are in the space, it's always good to look at some of the key champions that can then be able to spearhead the program and be able to be our focal person in some of the discussions that are beyond some of us. So we would like to have that discussion around who can be the champion for this program. And also, as we have all this discussion, we need to ensure that as you had in the morning, program around adolescents and young mothers is very important for us to take it up. As PMTCT program, I think that program lies within that space. So we may need to consider that as one of the programs that we may need to consider as moving forward. So in summary, some of these things we will be able to discuss with you after the workshop and be able to sum them up. So thank you very much, and I wish you well. It was a good deliberation. May God bless you. Asanteni sana.